Hey guys, what's up? So in this video right here, I'm going to teach you one, how to read your own blood work and see what or why we come up with reference ranges and why they are not optimal and what they are compared to based off the general population. That's number one. And number two, it's going to be 6 other blood markers your doctor's not ordering for you that you should probably get looked at least least once a year, ideally every 6 months or so, if you want to be metabolically healthy. So here we go. Let's do this. And I'm going to have this popping up on the screen here because I've made a slide deck for it as well. So you can read. If you're not an auditory learner, it's all good. We got you. I know you're not going to go ask your doctor. You're going to get the exact list, the conditions to get drawn under, because that matters whether you're fasting or not. So right now, first of all, I want you to go and get the most recent blood work that you got, like whether it was 6 months, a year ago, whatever it may be. Grab that, pull it up on your phone, whip it out, and we will start going through some numbers and see if you actually got this tested. First things first, a reference range is not a target. All right, so we have to come into reading blood work with that frame of mind. What is a reference range? A reference range is a bell curve of the people who walked into that lab. Could be a super healthy jack dude or some super fat on a tip assist scooter. You know what I'm saying? So normal means your average in a country where most men your age are already metabolically sick. Remember, normal is not optimal, and we want you thriving here at Trophy Dad Coaching. Now, I have to say this so the feds don't come after me. I am a coach. I am not a doctor. This is purely just for educational reasons only. It's not medical advice. Now, a little bit about me. I was working as a firefighter paramedic. I had brain fog, couldn't remember anything. I thought I was getting like early onset dementia, Alzheimer's. When I lost weight and went on a cut, I would lose muscle mass. I looked like a skinny little twink and I couldn't build muscle. So when I went on a mass gaining phase, I would just get fat. So I got my blood work done and it turned out that my total testosterone was 280. And the doctor told me I was normal to eat healthier and sleep better and exercise. So this is how I got down that rabbit hole. I was 33 at that time, I think, and discipline was not the problem. It was not. It was the ruler. So let's go over what your doctor ran, what they skipped. We'll go over the 2 ranges side by side, what it feels like when it's off, and what to ask for, and then stop and wait for the response. First things first, this one comes up on most panels, but they usually grab your total testosterone, yes, or they'll do some weird ratio thing. Most labs come with a total testosterone. Sometimes I've seen them not test for your free testosterone, okay? Now, total T is, think about your total testosterone as your gross paycheck, right? And your free testosterone is what's left, like after taxes, deductions, union dues. That's the stuff that's free floating around in your body that actually reaches the tissues. That's the part that you feel when you have optimal testosterone. So total testosterone, the conventional normal is anywhere from 264 to 916 nanograms per deciliter. It shows up as NG/DL. I want you thriving. Well, I can't say I want you. I would advise you to thrive at anywhere from 800 to 1,000, even 1,100. I'm talking Captain America levels, bro. You know what I'm saying? Now, when it comes to free testosterone, conventional data says anywhere from 8.7 to 25.1 PG per mL. I think that's picograms per milliliter. So 8.7 to 25.1. I like to see clients anywhere from like 50 to 200 picograms per deciliter. I want as much free T floating around in the body as possible to get to the tissues. Okay. There's no point in having a high total testosterone if you can't get to reach the freaking tissues. You know what I'm saying? Now, we're missing one other aspect here. SHBG. Sometimes it gets tested, sometimes it doesn't. What is SHBG? It's sex hormone binding globulin. Think of it as like a selfish girlfriend that wants all your time, and your time is your free testosterone. So it's going to bind that free testosterone. So you will see a relationship of a normal to high SHBG and a low free T, okay? For SHBG, conventional says 10 to 57 nanomoles per liter. Functional ranges are going to be 60 to 80 nanomoles per liter. And I say functional, that's for a natural, non-enhanced athlete, okay? Now, if you're on TRT or you're enhanced, you're kind of squinting at that number, that makes sense. Now, but we need to think about this with SHBG. That number is written, that 60 to 80 is written for a natural, lean, insulin sensitive guy. All right. SHBG moves the opposite of insulin. So if you're on TRT or any androgen load, SHBG gets suppressed and 60 to 80 stops being a target. So low SHBG can mean insulin resistance and or androgen load. And high, if it's high, we're looking into the thyroid liver, but that number only matters compared to your free T, okay? Now, and 264 is normal and optimal starts at 800. That is a 536 point difference. And that's where you feel like garbage, but the doctor's reading your chart and says you're fine. The doctor's reading the chart, not reading the patient. Next one up on our list is fasting insulin. Not when you're fasting, but insulin can cause that 2 o'clock crash. And we want to take this fasted first thing in the morning, hydrate, get your blood work done when you get the insulin, all right? Conventional says normal is between 2.6 to 24.9. It's UIUs per ml. But for functional, we want you low, anywhere from 1 to 5. If it's over 8, we start looking. We're on the hunt. We're on the hunt for some sort of what's causing the insulin resistance. Are you a super fat? Where's the glucose at? What's your liver doing? There's a few other markers that we would look at as well. Most panels get the fasting glucose. I'm just going to touch on this really quick. Fasting glucose, conventional says anywhere from 70 to 99 milligrams per deciliter. We like you functional 75 to 86 milligrams per deciliter here at Trophy Dad Coaching. Okay, so we like that fasting glucose to be nice and low. Now, your HbA1c, that is a 6-month snapshot. So by the time it gets taken, you're already sick if it's high, right? So conventional, less than 5.7%. In the functional ranges, we want you less than 5.2%, right? So glucose and A1C test whether the fire has already started, but insulin rises years earlier. So it's an early indicator downstream of the A1C and glucose. But almost no one runs this unless you say the word. Next one up is the HOMA-IR. It's an acronym. It stands for Homeostatic Model Assessment of Insulin Resistance. It's a calculation, all right? So you take your glucose, multiply it by your insulin, divide it by 405. If you're under 1, you're optimal. If you're over 2, you're insulin resistant. So if you have glucose and insulin on the last blood panel, do the math. Glucose times insulin divided by 405. I lost count. The next one on the list is hs-CRP. This stands for high sensitivity C-reactive protein. So this is the tax on everything else. Think about inflammation as the tax collector. It can drag your thyroid conversion, tracks with insulin resistance, and stands on its own as a cardiovascular risk factor. And this one almost never gets tested, and heart attacks are the #1 killer of first responders or firefighters. I don't know what it is for cops, but for firefighters, heart attacks are the #1. We're not testing for hs-CRP. Problem is if you draw it like 2 days after leg day or right after 48, the CRP can be kind of falsely elevated. So we got to make sure we rest and get a good baseline test. So what's the conventional marker? Less than 3 milligrams per liter is conventional, but here at Trophy Dad Coaching, we want you optimally living less than 1 milligram per liter, okay? The next one on the list is ApoB. I'm going to try and pronounce this. I'm almost going to butcher it, but it stands for apolipoprotein. Just say it fast and with confidence. Apolipoprotein B. I don't know, whatever. When you think of cholesterol and the different markers for cholesterol, LDL is how much cargo is on the road, okay? ApoB is counting how many trucks there are, and one sits on every particle that can enter an artery wall. So think about this. So ApoB is basically the particle that can stick to the arterial wall. If you think about it as a truck carrying cargo, it crashes into walls. Cargo doesn't. So cargo just kind of passes through, I guess. So your doc's probably telling you like, oh my gosh, your LDL is high, right? Oh boy, that's not good. And HDL low, blah, 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 blah. But no one's checking the ApoB. ApoB is the particle size and it's what sticks to the walls of your arteries. So that's how many particles there are. It's counting them and it sticks to them as well. So ApoB, apolipoprotein B, nailed it. It's the protein that sits on every artery invading particle, right? So we count the protein and then it's that particle that kind of crashes into arterial walls and sticks there. So that's the number, and the number is how much there is on the wall. So think about as the number of like vehicles on the road. Doc's probably saying, oh, your LDL is high, HDL low, blah, 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 blah. That's fine, but the LDL isn't what's sticking to the arterial walls. So for ApoB, conventional data will say less than 130 milligrams per deciliter. Functionally, we want you less than 90. We want you living optimally, less than 90. Not a lot of particles crashing into the walls of your arteria. But I know your doctor tested for your triglycerides and HDL, so we can calculate a ratio. So your triglycerides to HDL ratio, I can talk. If it's less than 2, that's optimal, right? So we look at all these different metrics and ratios when we get your blood work done to assess your cardiovascular risk. If you want to go even deeper, you can ask for lipoprotein A. It's genetically set. You can kind of train and diet it away, but sorry, mom and dad, or thanks, mom and dad, for giving me like high LPA if that's your thing. For LPA, functionally, we want you less than 30 milligrams per deciliter, but conventional says more than 50. So take that for what it's worth. Now, I mentioned the triglycerides to HDL ratio. Take your triglycerides divided by HDL. Do that right now. Like I said, under 2 is optimal. Under 3, we're kind of kissing into metabolic syndrome territory. And then we get into the thyroid. Oh, man. Okay. So for the thyroid, doctor probably just pulled TSH, which is thyroid stimulating hormone. That's just the signal. That doesn't test if it's converting downstream, and it's not pulling the hormone. So it's like, think about like if a car is in neutral and you're pushing the gas pedal down, but it's not going anywhere. That's what testing for TSH is. Now, you need to get a free T3. They'll test for T4, but that doesn't get to the tissues. T4 gets converted into T3, free T3. For TSH, for thyroid stimulating hormone, conventional is like 0.45 to 4.5 UIUs per ml. For functional, to have you living functionally and optimally, we're looking at 0.8 to 2.5, right? So we're kind of compressing that gap a little bit. Now with your free T3, they say, it's good, you're good anywhere from 2 to 4.4 picograms per milliliter. I don't know why they test it. It's just all different measurements, but functionally, we want you living in the 2.8 to 4.0 picograms per milliliter, all right? So reverse T3 sits in the receptor cell and it blocks the active T3 hormone. Cortisol, chronic diet restriction, low vitamin D can all drive up reverse T3, right? So we want the full panel. Thyroid stimulating hormone, which is a signal that sends it downstream to signal your pituitary gland, signaling your thyroid to release thyroid stimulating hormone, which gets converted, which is T4. And then there's a conversion mechanism that happens, like if you really want to go autistic with it, you could go down the rabbit hole, but there's a conversion that happens downstream that gets to T3, gets converted to T3, and that's what goes to your tissues. T4 doesn't get to your tissues. T3 does. And then you check the reverse T3 to see if that reverse T3 is binding up that free T3, and it goes back into T4. And we're just stuck in this like flywheel infinite loop. Sometimes clinics and doctors will pull estrogen or estradiol, but we want to go a little bit deeper. And that's what we do here at Trophy Dad Coaching. Like I said, you want a estradiol sensitive assay, okay? That's the key right there. And we don't want to crash your E2. Some guys have it backwards where like, oh, high E2 is so bad, you're estrogenic, and we're going to crash it. Trust me, I've crashed my E2 before, and you feel so terrible. You feel like you're coming down with the freaking flu. It is awful, all right? So sensitive estradiol in men, conventional ranges are 8 to 35 picograms per milliliter. Functionally, we want you at 20 to 60 picograms per milliliter, okay? I like my guys just a little bit higher, anywhere to 50 to 60 is where you feel really good. Your joints feel good, you're recovering good, you have good libido, sex drive is through the roof, same thing. Waking up, that's some good morning wood. And if you want to take it one step further, we can do a ratio. Take your total testosterone, divide it by your estrogen, your E2, and if it's more than 20, that's optimal. That's the optimal range we want, right? So we look at the ratios as well, all right? So 2 things that can drive up estrogen. If you're super fat, get on a diet, get lean, right? And you're an aromatizer if you are injecting TRT, right? If you're taking exogenous testosterone. If you're fat and taking exogenous testosterone, it's kind of a double whammy. So get unfat. So you have to ask for that sensitive E2 by name. And then if you have a clinic or doctor that's just willy-nilly throwing you an AI like it's a Skittle, you're going to crash your estrogen. And like I said, your joints, mood, libido, energy is just, you're going to feel so awful. I'd rather live on the higher end of E2 with a little bit more water retention then crash it. It's terrible, 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 terrible. All right. How are we going to get this drawn now? In the morning, fasted, hydrated, not alpha 48, hydrating with multiple cups of coffee. Okay. And then ideally after 3 to 4 days of hard training. I know it's not necessarily like doable for most guys, but at least try. Okay. Because the training dehydration and a rough shift can all inflate your high sensitivity C-reactive protein, your hs-CRP. Also elevate your liver enzymes, your hematocrit, especially your hematocrit if you're dehydrated. And then you get a panel that's you just don't have good data on based on the lifestyle leading up to that. Okay, so to summarize, what task for? Total T, free T, SHBG, sensitive estradiol, TSH, free T4, T3, reverse T3. If you really want to go down the rabbit hole, TPO antibody, not super necessary unless you have thyroid issues. We got to look at the whole panel. All right. And then we got to look at your fasting insulin, fasting glucose, HbA1c. We're going to take a look at your ApoB, your LPA, lipoprotein A, and the full lipids, and then hs-CRP. I do want to get a vitamin D. I do like a vitamin D hold. And there's a lot more I can go down on this that's way deeper than this video. And if you like this and you want more educational info from a somewhat retarded former fireman, let me know in the comments. But remember, morning, fasted 3 to 4 days after hard training and hydrate. Make sure you're pissing pretty clear. All right. And if you're tired of spinning your wheels with your diet, energy, routine, can't lose weight, can't seem to get a hold on your life in general, fill out the application below. Let's have a chat, and I'll see you on the next video.